Good afternoon, everyone. I am Nikki Hayes from the CDC, and I am excited to be able to moderate the Q&A session of this summit today. So I want to first of all begin by thanking you, Dr. Winn, and also thanking you, Dr. Cuellar, for such amazing, amazing presentations. There are already all kinds of comments in the chat and in the Q&A, and I would like to echo one of the comments that were made was that Dr. Winn, you always inspire us so much. Every time I hear you, I'm ready to just say the benediction, and this is the method is coming out of me, but I'm ready to say the benediction and go do some work. So thank you both for such inspiring presentations today. So I have a question, and I want to invite all of you. Number one, I want to say thank you for joining us today. There are over 300 people on the call, and that's amazing. So thank you all. And I want to invite you all, if you have questions that you would like for us to answer, while we're here today, we'll get to as many of them as we can. Please feel free to put them in the Q&A. And as I said, we will address them as many as we can. But I want to start out by asking both of you, because you are both so actively involved in advocating for and promoting approaches that are really tailored to the community so that we can address disparities and we can improve health. And Dr. Winn, I especially appreciate that ZNA is very much so as associated with risk, and acknowledging that is absolutely critical to the work that we want to do around prevention. So how can attendees help their organizations really better realize this and understand the importance of this approach? And how can they take steps towards helping their organizations really move in that space and in that direction so that we can make a difference? How do we make communities more visible? And the question is for you both, and so please have at it.
I was going to go after. Listen,
I love the question because, of course, the CPSTF is all about the community-based interventions. And by that, we mean they can be through a public health department, a school, a hospital, an employer. It's a loose definition of community because communities can come together in so many different ways. And I think that's the beauty of our definition of community, and also provides the richness of the intervention approaches that we have the privilege of looking at. And even this particular recommendation around patient navigation is centered around patient navigation hosted by or coordinated by health systems. We have another recommendation about community health workers and their ability to improve cancer screening rates, again, for cancer, breast cancer, cervical cancer, colorectal cancer, that's separate because sometimes those are not linked to hospitals at all. That community engagement piece is organized and hosted elsewhere. We have a broad definition of community, and I think that provides the richness of the interventions we can review.
And I think I'll add to that there are two things that became apparent to me doing this work, particularly as a cancer center director. One was that we were not getting the information out or involving what I call the impact makers of the primary care docs. In fact, much of what we did, we set up screening and we do all these wonderful things and we talk about the community and education fairs. And I still would have primary care docs out in the community, the people on the front line asking me, well, what the hell do I do about this GRAIL, or what do I do about this, or what's the real facts about that? And it's as if we thought that they just magically were getting this information. The funny part is, what I found out is that it was not only my community members subjected to Dr. TikTok and Google, many of my healthcare providers were too, because the information wasn't so readily available or made readily available to them as well. So making them a part of the One Team, One Fight effort has been a real, I think, cultural change for us here, but a necessary one. And a second one, not to just come off all hood-like, but honestly, I learned from Danny Davis, Bobby Rush, and I'm learning from folks here like, now Representative McClellan. People want jobs from those neighborhoods. The funny part about it, about navigation versus activation, is that I struggled for a while about why we were having all these folks in the community. If I had a rich person they would essentially activate a health system by picking up a phone and essentially calling either me or someone part of my cancer center and saying, I have a sick person and I want them seen. That person didn't need to go through any freaking training. That person needed to have an IRB. That person essentially picked up the freaking phone, called, and activated a system for their loved one or for their friend.
So the hard part of the hard part is, but how? And there are a couple of questions that we've received already about funding. So who funds patient navigation? Is it uniformly funded across different health centers? We understand that going in the community is absolutely important, but where do we get the funding to actually make sure we have the resources to make it work?
That's the job. Right now, the hospital, my health system is funding ours as not just a pilot, but I take money out of the cancer center and employ now people strategically within the neighborhoods that I call my community activators that have one number that people know them. They know if they need help, they reach out to them and they call. So it's an experiment. I'll let you know how it works. But to your point, we pay whole much billions of dollars for multiple medicines, even immunotherapy, checkpoint inhibitors that now we have 60 or 80 that do the same freaking thing, but we have not actually redistributed that money to things like how do we make sure that navigators and activators are paid. So your point is well made that right now it's very fragmented and on very local levels. It would be really nice to have more of a national cohesive approach about the funding of these things, because I think it'll be necessary.
Absolutely. Thank you. And so, Dr. Cuellar, do you
Sure.
have any?
I can add a little bit to that. At the CPSTF, we also do economic reviews. And so you can go to the communityguide.org and look at our economic review to see the economic findings related to these interventions and how they are net have positive economic impacts. It's a little bit different than asking who pays for the service. So we're showing that you get savings back from delivering these services. Who funds it? I do know that Medicaid funds community health workers in some states. It's not a federally mandated service, but one can leverage Medicaid financing for individuals who have low incomes and are eligible for Medicaid, for example. But one can take this evidence, and I'm going to keep pushing the communityguide.org because it just has so many examples of where these services have been implemented, how they've been implemented, how some considerations for that to help make that argument both for its effectiveness and for its cost effectiveness.
Great, absolutely. So another question is, how can we best ensure that we're leveling the playing field as we select communities and locations and partners? And this is very specific to mobile screening programs. Any tips on how to most effectively reach under-screened populations?
So our focus was definitely on underrepresented populations. And as I said, we had targeted interventions for different groups of racial and ethnic backgrounds, for example. We have a recommendation around a multi-component intervention, which leverages the ability of community health workers who have local knowledge embedded in their communities, that combined with removing some of these structural barriers. So really a health system is able to change where it delivers services and at what times of day those services are delivered. But the community health worker addition to that, which is that local knowledge that they bring, is another piece that's important and appears also on its own and in a multi-component intervention.
Great, thank you.
I just quickly would say that the mobile, and we're part of that too, that the mobile movement, but the mobile movement can't be hit or miss. It can't be you show up 1 year, but then 3 years later. I mean, so whatever we do, whether it's dental, it's primary care, whatever, I think people are just wanting us to be consistent. Do you know when I'm going to show up, and do I show up regularly at whatever schedule that is, right? Because it gives the opportunity for communities to then know and organize as well. I think we do them at the service and us at the service when we do the hit and miss sort of phenomenon. We feel like if we got the resources, we're going to go in, as opposed to what is a regular routine, even if it's once a month, once a quarter, twice a year, but can I count on you to show up and show out every year or show out whatever, cadence? I think that from talking with community folk, that's something that I think we need to all figure out. How do we work on, not show up, blow up 1 year and then never come back, but how do we stay consistent so that there is a consistency that we're showing up even when your grant funding runs out?
Absolutely. That consistency builds credibility, so that it is absolutely important. Any suggestions, and I'll point this to you, Dr. Winn, initially, how are we encouraging and facilitating diversity in the medical field? Some more news came out sharing about how Black folks are healthier in communities where they have Black doctors. So the medical system is a community that we need to pay attention to. And so how are we doing that?
Well, there was once upon a time where I thought we were trying to do that and making some progress. And then all of a sudden, I mean, I just can't, I mean, listen, this is why I never get invited places. I just, you know, I just don't. But with if we look at our numbers, and I'm just looking just at a small number of African-American men, those numbers are not actually increasing. When I look at the recent issues that are happening across the country in many of our states, not just, it's easy to just pick on right now Florida and Texas, but there was much more than Florida and Texas across the United States that are actually thinking about, in some ways, either dismantling equity, diversity, and inclusion, or actively just not talking about it. I think that at some point we actually have to get real, that we know that there is a lot of literature that says when you bring different voices to the table, everybody benefits. Not because Rob Winn says it, but because the data actually, we do have data to sort of point it out, whether it's in a corporate or health system. So I'm hoping that at some point we will come back, break the fever, come back to our senses as a country and recognize that the organized sort of approaches to make sure that diversity is there and making accessible people is going to, at the end of the day, help us all out, including whether you live in a Bettyville, Kentucky, or you live on the South Side of Chicago.
Thank you. So, Dr. Cuellar, I'll ask you this question. Any suggestions on how we might work towards eliminating the backlog that we see as a result of COVID? Many centers are, are stretched very thin workforce-wise. So how do we go about really advancing this initiative around getting people back into screening when in some places we really just don't have the resources to meet the need?
Right. I think that's a hugely important question, and it gets to Dr. Winn's point also about the message to the community and the fatigue that's in the community and the priorities of the individuals in the community who may be focused on wanting a job. I wish I could say our intervention looked at people's understanding of the importance of, for example, these screenings in cancer prevention. I just think this is an enormous challenge. We have such backlogs in so many things. And then trying to make sure that as we come on board and bring our services back online and bring our patient populations back online, that we do so in a way that's equitable, that we have an understanding of where the gaps were the largest. And I don't know that and those are that's descriptive information that I really wish we had more of, which is who have we not seen in a while and how do we bring them back? We have some excellent methods for engaging individuals and bringing them to screening and improving it by over 10 percentage points. That's really quite marvelous. It's not at Healthy People 2030 goals. And I'm sure we've slipped since then due to COVID. But it's being able to put those in place again. We have had more and more states expand Medicaid, for example. That's a stable financing base. Our economy is good. That's helpful for health insurance and health insurance coverage through employers. But as you say, it's still difficult. And I encourage people to use these materials as much as possible to help make the case.
And I will say, and I'm not a presenter, but I will say that here at CDC, one of the things that we're just beginning to look at now, even across the local and state health department workforce, is really looking at how COVID has impacted workforce in that perspective, because we hear that a lot. We see that a lot, where it's very difficult for programs to just ramp and amp back up because staffing has changed so significantly. And so how do we address those issues as well? And I do think, that marrying and looking at both the public health and the clinical health together is going to make a difference in us really understanding, what the workforce needs are, and then how do we move forward towards addressing those. So this question is for either of you. How are cultural and linguistic social economic factors being considered and addressed when we're developing and implementing community level interventions, especially around early detection and prevention?
So Alison, I'll let you go first.
Why don't you go ahead?
real talk. In general, we still have a one size fits all. We don't do, I think, as WBEH says, think like the wisest of men and women, but communicate in the language of the people. It's allowed Dr. Google and Dr. TikTok to almost have a sort of space and place in which their first referral comes to, well, what's on Google and what's on TikTok, not knowing that that's just taking lots of people, but it's not thinking specifically about them. We have actually, I have made it a point that it shouldn't just be my outreach and engagement people who understand and who are actually motivated about learning how to be more effective communicators. This is something that I thought was going to get me fired, but I was ready for it. I actually thought that both all my administrators, but importantly, my clinicians and even my basic scientists needed to be a much more effective at the way that they communicated. So much so that I had several what would have been uncomfortable conversations that turned out to be wonderful conversations of putting a mirror to the face of my basic scientists and my clinicians about how they sounded. And the reflection wasn't always good. The wonderful part is that once they got over their hurt and they got over their embarrassment and they got over actually understanding that they may not be the smartest person in the room on all things, something beautiful happened. I now have, I swear to God, clinical trialists and basic scientists really trying to learn more and do more and understand that grace matters, that you're not always going to get it right, but the community is willing to give you grace if you're willing to also give grace. Mm-hmm. And I don't know where we are. We're at the very beginning of this journey. Most of us don't do it well. Most of us think of it as something that, oh yeah, as an afterthought. But I do adhere to the WBEH principle. Think like the wisest of men and women, but communicate in the language of the people. And I think that we can do much better across the country.
Thank you.
Wonderful remark. I think kind of going back to the evidence that we reviewed specifically in this context, what's I think interesting is that we found insufficient evidence for things like mass media communication. For two of the cancers group, we didn't have sufficient evidence for. Where we found the stronger evidence was on the one-on-one. Now that doesn't really get to the messaging, but it does get to the messenger, for example, that this we're going to need to understand better some of our broader communication strategies and their effectiveness to move this forward. But for now, combination, and interesting also, we had insufficient evidence for things that I think people might reach towards, which are client incentives and provider incentives. We don't have the evidence for that currently. Really one-on-one education plus these structural barriers, plus using your community health workers, that combination approach, for instance, is, but that we don't get into the actual communication messaging itself, and I wish we could. I wish there were enough studies to do that.
So just what I thought would happen is happening, and we're running out of time, and I don't have enough time to ask all the questions that I wanted to ask. But I do have one last question that I want to see if you guys can tackle in the minute or so that we have. Can you speak to how clinicians and researchers, and we've started this conversation a bit already, but how can clinicians and researchers and public health practitioners and others really collaborate and leverage what the strengths that each of us have so that we can really make a difference in this prevention effort? None of us have the resources to do this by ourselves. So how can we better leverage, our community, so to speak, in this regard, so that we can kind of capitalize on the wealth and the richness that we see coming out of each and really bring them together well?
I agree, Nikki. I mean, there is richness when they come together, when use what communities are doing and allow researchers to study it, so then we can document it and pass it on to the next community and know where things are working. I think those are marvelous opportunities. They take a trust building. They take typically a history, just from my own experience of baby steps and then moving on to the more difficult lift. But then they become something that your community becomes accustomed to. But there is a certain amount of research imposes to document what happened and whether or not it worked imposes some constraints on communities. And I can see how that can be difficult. But of course, the payoff is then we can compile it and share it with others and know. But no one's going to be surprised I'm going to say that, right?
Yeah. I was going to keep it real short. I'm going to get like, I don't know, Bootsy Collins, James Brown on you about getting on the one. We need better data that surrounds us so that we all are, that it's not only useful, but usable for all parties. Mm-hmm. We're trying right now to come up what we call data that actually matters to communities by actually getting how they vote. So we don't do the zip code thing anymore. I go by voting districts in a sense of from alderman and council person to other, so that we can actually have an ideal of how all parties could align around the data and then make some action. So I think we're working our way there. So I'm excited about our future.
Thank you. That's a very important point. And I do just want to bring up one point that came up in the Q&As that we didn't get to address, is that when we're looking at disparities, we are looking at more than just Black and white. Now, and I don't mean to say just as in to minimize it, but we're looking at, we're looking at poverty, we're looking at where people live, we're looking at all of these things. And so to your point, how do we make sure we have the data so that we can have these discussions and really be able to justify where we want to be in our work? So we are out of time. I do wanted to again say thank you, Dr. Winn. Thank you, Dr. Cuellar. We really appreciate your being here today. This has been amazing. So thank you all for joining us as well. Next, you will hear from our sponsor, Grail, and they're going to have an update on emerging multi-cancer early detection technology. And after that, please don't miss our breakout sessions and check your emails for information and links to join your group. Thank you a lot.
Thank you so much.